Good morning. Thank you. It's an honor to be here with you this morning. And thanks, Mark. And I also want to thank Virology Education, IAPAC, and VIV for inviting me to be here today. I'm going to shift gears and talk a little bit about healthcare facilities and stigma in healthcare facilities. You may wonder, why am I going to talk about Asia? This is where we've developed a model, and I do believe that this is a very replicable model. Okay, there we go. So I think, as we know, stigma and discrimination still have terrible consequences. And the very people who we are meant to be protecting, supporting, and healing are often discriminated against the people who should be in their care. So we're discriminating unintentionally toward people with HIV for whom we're supposed to be caring, and denying them access to critical HIV services that will result in more HIV infections and more deaths. And to reach the end of the AIDS epidemic by 2030, countries will need to use the powerful tools available, hold one another accountable for results, and to make sure that no one is left behind. The bedrock of the AIDS response is an absolute commitment to protecting human rights, and nothing other than zero discrimination is acceptable. And so the logic model for this, and I credit Laura Nyblade from RTI, who's done some pioneering work in stigma in healthcare facilities, is that there are immediately actionable drivers that we can address: fear of transmission, awareness of stigma, attitudes of healthcare workers, and institutional environment of healthcare facilities that lead to experienced, anticipated, perceived, and internalized, and strengthening of internalized stigma, with avoidance of healthcare and harassment in healthcare facilities. And then this directly affects people's access to the services related to the 390s and to outcomes of viral load suppression. And so we need to act on those drivers. And you'll forgive me a little bit because it's a little hard for me to focus on the screen, so I'll try to, just in case if I'm stumbling a little bit. And so I want to also, in addition to thinking about epidemic control, which we do with the 90-90-90, to apply the lens of quality of care and quality improvement. And one of the key domains of quality of care is equity. And that means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status, and I would include, obviously, medical condition. And in the recent Lancet Commission report on high quality health systems, they made a very clear statement that we know that quality of care is worst for vulnerable groups, including the poor, the less educated, adolescents, those with stigmatized conditions, and those at the edges of the health systems. And so in quality, we like to think of two major domains. There's technical quality and there's experiential quality. And in the domains of quality, we think of technical quality as effectiveness and safety, and that relates to what we think about as providers when we deliver care. But then there's experiential quality, which is how the people we care for perceive the care that they're being given. And that relates back to equity and people-centered care, so we now have covered 4 of the major 6 domains in standard definitions of quality. So Dr. Castell talked about the fourth 90, and you're the only other person I've seen do this. But I think it's really important for us to think about, because we know that stigma is interfering with our ability to reach the 390s. And if we think about what that fourth 90 is, it's health-related quality of life. And we want to be thinking about that as we work toward ending the epidemic, or we're just simply not going to get there. And so the aims of our initiative was to apply quality improvement methods through a multi-country learning network in Cambodia, Laos, PDR, Thailand, and Vietnam, to support ministries of health so that they could then implement quality improvement learning networks focusing on stigma reduction in healthcare facilities by testing changes, instituting routine measurement of stigma in their programs, and fostering peer learning between the countries. That this would spark them to implement policy initiatives to encourage stigma reduction in healthcare facilities, to empower patient groups to take on active roles in quality of care that is discriminating at facilities and regional and national levels, and to exchange knowledge in the network that will advance how stigma can be reduced in healthcare facilities. And so the schematic for this is that we are working, we were funded to work at this multi-country level. And then the countries would then create their own national quality improvement learning networks of selected facilities. And the facilities would then report data and test changes. And that would feed back up to share the knowledge in country and then also in the multi-country learning network. So the way that this looks, traditionally in quality improvement, we look at clinical performance data and we act upon it with QI to achieve outcomes. And in our initiative, we were using healthcare provider survey data, which I'll explain shortly, as well as patient feedback, and using those sources of data to influence our quality improvement work, so that we are uniting the survey and clinical performance data to get a more comprehensive picture of the quality of service delivery, and using quality improvement to give us a very systematic approach to interpret this snapshot of service quality and improve the gaps that are identified in the data. I'm going to skip the basics on QI, and if people need a refresher, you can ask me at the discussion. But we used this validated survey tool, and I again credit Laura Nyblade from RTI. This was a validated survey instrument for health facility staff that was field tested in 6 countries and was piloted in the Southeast Asia region. And we took, this item has 51 elements, and we knew that would be impossible to use on a regular basis in healthcare facilities. And so in a planning meeting, we brought our country teams together, and using a modified Delphi approach, they prioritized 8 indicators from that survey. And then the idea is that this would be administered to all healthcare staff in the facility, not just those in the HIV clinic on a routine basis. And to remind us that when people come into the hospital or the clinic, they're not just seeing the HIV team. They have to get x-rays, they have to get blood drawn, and they have to register. So they have encounters with a lot of people where they may encounter inappropriate behavior. So in this survey tool, there are 5 major domains of stigma. One related to infection control, and these relate to those drivers that I showed you in the logic model. Attitudes about people with HIV in key populations that affect willingness to treat. The actual manifestations where people observe behaviors that are stigmatizing and unfriendly. Health facility policies that relate to training, supplies, and other policies. And then there's a special module focusing on pregnant women living with HIV. So the common measures that the group decided on were, in the past 3 months, have you observed healthcare workers unwilling to care for somebody living with HIV or thought to be living with HIV? Do you typically wear double gloves when providing care or services to a patient with HIV? Do you strongly agree or disagree that women living with HIV should be allowed to have babies? And how worried would you be about getting HIV if you drew blood from someone living with HIV? In the past 3 months, have you observed healthcare workers providing poor quality of care to someone with HIV? Do you agree or disagree that there are enough supplies in your facility to provide safe care? Do you typically avoid physical contact when providing care for people with HIV? And does your facility have written guidelines or policies addressing discrimination against people with HIV? So the baseline network results from across the countries, and this is just aggregated data, showed us the following information. And I highlight here that nearly half of the healthcare workers in the facilities really didn't believe that women with HIV should be allowed to have babies, and that a third were wearing double gloves, and 20% had actually observed poorer care to people with HIV. So we clearly have a problem that needs to be addressed. Now, the second round of data is shown here. Again, this is crudely aggregated data from across the countries. And there's some improvement, which you can see on the next slide, particularly with related to agreeing that pregnant women should be allowed to have children, but there's still we still have a long way to go. And I think you see that across the board with those key measures that I showed you before. So on the other hand, I think we see some really good news in some of the countries, and in Laos in particular, we've seen remarkable progress. Now, one of the caveats here is that they've implemented it in their 11 ART sites. So these are hospitals that have already been somewhat acclimated to providing HIV care, although they do survey all staff. But just to point out that there are a lot of caveats with the aggregated data and that the real meat is in the country-specific data. So the number of healthcare workers surveyed varied drastically between the countries, and the majority of healthcare workers, which is now in the tens of thousands, are from Thailand. Data collection methodology differs in the countries. The rounds are not timed consistently. There were a lot of new sites recruited in round 2 in Thailand. Not all sites reported in Cambodia. And then we've also observed that when there's a sampling process going on in very large hospitals, people may be sampled, healthcare workers may be sampled that didn't actually receive or weren't part of the interventions. And so we're seeing a mixed group of respondents from people who actually were targeted through interventions and some who were not. The idea being that some activities will spread across the hospital, or we can target areas that need more intervention. And then there are minor variations in the questions in different countries. Now, across the networks in the countries, the facilities have tested a wide range of interventions. What we have done is group those interventions into some domains related to the chronic care model, for those of you that are familiar with. There are changes made in the care delivery system. I'm not going to read them all, but they involve things like redesign of clinic flow and having a very specific warm welcome when people come into the clinic so that they feel more comfortable the minute they walk in the door. A lot of knowledge management and decision support interventions that include feedback of data. Routine performance measurement related to stigma, something that has not been done routinely, and integrating that into routine quality improvement work. People-centered care, having patients directly involved, and I'm going to show you an example of that from Vietnam that's really impressive. And of course, having peers working in the clinic to address patients' concerns directly and work with them as they walk through the clinic. And then general health system activities, which include policies and regular committee meetings in the hospital to talk about stigma. And we've seen some hospitals actually develop stigma and discrimination rounds and present cases so that the whole staff can learn about what's happening. We produce best practice documents, spotlights. 4 have been produced so far, and this just again is a way of sharing information about things that have worked in facilities, and I'll show you the website at the end. So here's an example from Thailand. There was a significant issue with fear of acquiring infection among healthcare workers, and they also surveyed patients who felt that they had, 10% felt that they had experienced discrimination, and 35% said their status had been inadvertently disclosed in the hospital. And this is a very common problem across all the countries. And so they implemented a number of interventions which involved reforming the queuing system so that the people with HIV were not put at the end of the line, particularly for dental services and the operating theater, to stop a zoning system in inpatient wards so that people were not identified right away, not separating equipment, and just heightened vigilance for the enforcement of the changes in policies. Because we're also working at all levels of the system, national, subnational, and facility, I'm showing you an example here from Vietnam, where the country has adopted a formal decision, what they call a decision or a law that is about anti-discrimination against HIV, people living with HIV, and they have national training curricula on PEP, PrEP, and a major campaign now for U equals U, which in Vietnamese is K equals K. And training on sensitization for working with people representing key population groups. I'm going to skip the fishbone. Okay, so then in Laos, here's a QI intervention where we see a group of things happening, where this was, again, this example of greeting at the entrance to the facility, reinforcing policies with all staff, with weekly case study conferences, and participatory training for all staff in the hospital. So a lot of this work is actually spread from the HIV clinic to the routine ambulatory clinic as well. And it was really gratifying to walk in the door and see this 90-90-90 poster in this hospital. This was at Champasak Hospital in Laos. Now, we also focus, as I mentioned, on patient experience. And participating ministries of health are choosing their own way of capturing experience. So this may include surveys, exit interviews, patient forums, storytelling, comment boxes, and consumer advisory boards. And I will repeat this, but I would underscore that the challenge here is how do we make this routine in clinical practice? And so to facilitate cross-country comparison, we also developed some common questions for patient experience. And these are very similar to standardized international tools, which ask people if health information was explained clearly, was the clinic welcoming, were they treated with respect, was there privacy and confidentiality, did they experience discrimination, asked directly, sorry, and then were they involved with decision-making, and did the provider spend enough time with them at the visit? And again, in Laos, in this hospital, I have visited many hospitals all over the world, including in many countries in Africa, and many have comment boxes on the wall. And the typical response when you ask people what they do with their comment boxes is nothing, or they don't look at the responses that are in there. And what was so remarkable in Laos was that in this cluster of 4 hospitals in the south, as they open these boxes every week, they review the comments, they pull out the key issues, and they act upon them. And if there's system issues, they integrate it into their quality improvement work. And if it's an individual issue with a provider, the hospital director brings the provider in and discusses the issue with them. So it's a very enlightened system in this particular hospital. And it also happens to align well with their national quality initiative, which includes what they call 5 goods and 1 satisfaction. So it really links with this national patient satisfaction initiative. Then Cambodia Linkages is managing the project, and they do patient survey, and they're looking at patient satisfaction. I can't read the results, so hopefully you can, but I can't from here. But one of the things they did is they also looked at discrimination in the ANC clinic and the sexual and reproductive health clinic, and patients experienced more stigma and discrimination in those clinics than they did in the HIV clinic. So they then become the target for interventions. And here I'd just like to mention that interventions, as I showed you in the change package, it's not just about training, okay? You can train and train and train, but if you don't start to make changes in the system, you're not really going to see long-lasting change in attitudes and behaviors. Now, I mentioned Vietnam. Here, this is the Consumer Advisory Board, and this has been adopted formally in a province called Binh Duong. And here, now, every hospital is expected to have an HIV Consumer Advisory Board. And so these are the formal documents and a picture of the Consumer Advisory Board. And here, the CAB, as we call it, the Consumer Advisory Board, discuss quality of HIV care directly with faculty. They get feedback from a hotline and comment boxes and exit interviews from other people attending the clinic, and then they use that in a feedback process to drive interventions and improvement with summarizing of the information, and they feed the information back to the consumer advisory group. So again, this is a really proactive model in involving people with HIV. As a result of the feedback, they've expanded their number of days per week in the clinic, which was a major complaint, and they took a lot of steps to improve confidentiality in the clinic, which was, again, another huge problem. And so, again, you see an example of how this can be put into practice. Okay, so one of the challenges that we face, particularly from donors, is, okay, so what's the link between what you're doing and impact? Can you show that this actually improves your 90-90-90 outcomes? The short answer is no. There's not a very direct correlation. And there are challenges. It's very hard to link individualized data from patient and provider surveys to clinical performance data in terms of who was coming into the clinic at a certain time, and just drawing other direct relationships. The data collection methodology for doing that is extremely resource intensive, and we weren't funded to do that, and I don't know that anyone is. And the clinical performance data, as we know, underestimates the problem because the impact of stigma and discrimination is that people don't come. So if you're only interviewing patients in the facility, then we're missing the people who may be most severely affected by stigma and discrimination. And then also, as we aggregate performance data in the results, even though the aggregated number may be high, if we don't unpack that by disaggregating it by key populations, we may be missing some very key information about stigma and discrimination. That said, literature is now emerging that directly correlates stigma with key clinical outcomes, and the first paper with the direct relationship to viral load suppression was published from the US among African American women, which are a marginalized group in the United States, that showed a direct correlation between stigma and poor viral load outcomes. Question, is engagement and adherence a proxy for viral load suppression? I think some of us would think so. And so is it a direct outcome? And there's a lot of literature that shows that. And then finally, we know that self-efficacy, if I believe in the effectiveness of my treatment, that I will likely have better health outcomes. And so we also added some questions focusing on literacy in the network, and these have been piloted now as well. And I think one of the things that we have seen is that, surprisingly, a fairly high number of people don't know if they're suppressed. And these are in general clinics. And I stop here to emphasize that because if we are rolling out U equals U as a campaign, then we need to focus on making sure that the people in care understand what we mean by viral load suppression, how often it needs to be checked, and then, of course, how that relates to transmission. So aggregated results about our network through December, we've held 6 multi-country network meetings, and 83 facilities have been involved across the 4 countries in 29 provinces. Over 17,000 healthcare workers have completed surveys, again, the majority from Thailand, where they've scaled this up very quickly. As of September, across the network, 40% disagreed that pregnant women living with HIV should be allowed to have babies, although that's dropped from 51%. 13.5% had observed colleagues providing poor quality of care, and slightly decreased from 15%. So just again to underscore that this is an ongoing problem and we need to keep addressing it in a regular way. Activities to assess experience and treatment literacy through common measures are currently being implemented with the goal to routinely monitor and act upon the data emerging from them of ongoing S&D activities. And we've seen 27 strategies and interventions that have been tested to address those 4 drivers that I mentioned, including fear of infection, attitudes, observed behaviors, and institutional environment. I think what's most important for us is that there has been an emerging consensus, which for those of us that have been around for a while and have watched providers throw up their hands and say, well, there's stigma, what can we do about it, is that stigma and discrimination are actionable in healthcare facilities. We can do something about it, and we have ways that we can learn from people that are doing something about it.